Influenza infections are associated with significant morbidity and mortality. Most people recover from uncomplicated influenza, but influenza can cause complications that result in severe illness and even death. Some patients are at higher risk for experiencing these complications. This program, entitled Tackling Influenza in High-Risk Populations, addresses these issues. I'm Dr. Sharif Binyamin Mossad, and I'm joined today by Dr. Jack Perkins and Dr. Richard Zimmerman to discuss important questions about how to care for these high-risk patients. We also have Mr. Christian Nickel with us today. Mr. Nickel is a patient of mine who's joining us today to share his recent experience with influenza. The CDC recommends testing and treatment for influenza to be specifically attended to in three groups of people. People who are hospitalized with the flu, people who are not hospitalized but have severe influenza, and people who are at high risk for influenza-related complications. Our program today is going to specifically focus on this last group of people. So, Dr. Zimmerman, can you please go over with us some of the complications of influenza?
Sure. And I think as clinicians, we've seen severe complications of influenza. We've seen exacerbations of asthma, of heart failure, of COPD. We've seen pneumonia. We've also at times seen myocarditis or encephalitis. I think what catches us the most as clinicians is to see the air hunger when someone is gasping to breathe and really struggling. That really tugs at our hearts.
Dr. Perkins, who are these specifically high-risk patients that you could think of so that we can remember them?
So I think the important thing is to understand that there is a fairly large list of patients who fall into higher risk categories, and thinking that you're going to remember all of these without having to look it up is a tough task for all providers. Some of the high-risk patients we'd all recognize: patients who are on chemotherapy, patients who are being treated otherwise for active malignancy, patients who have HIV, patients who are immunosuppressed in many forms, diabetics, patients who are younger than 2, patients who are older than 65. However, they've added some new categories, such as body mass index greater than 40. Well, depending on where you live, that could be a lot of your patients in terms of falling into high-risk categories, and there's more. So I think it's really important for providers, especially in any time you're thinking of flu-like illness, making sure that you think about, like, is the patient in front of me in a high-risk category, and just using resources. Go onto the CDC, go onto the IDSA, and just making sure, like, do you fit one of these categories, because it's going to change my approach to evaluation and treatment in this patient.
So, Dr. Zimmerman, can you review with us some of the issues related to misuse of antibiotics as it relates to influenza?
Sure. There is a paradigm that now is being expressed called the paradox of the antibiotic misuse, antiviral underuse. And that paradigm is, I think, a neat concept to be able to put this in perspective. Antibiotic misuse in one of the CDC studies occurred in nearly 15,000 outpatients. And that just shows the tip of the iceberg of antibiotic misuse. I think we've all seen the problems. Not only is there a cost, but and the spread of resistance to antibiotics, but there's the reactions. And I think C. diff most comes to our mind as we see people with prolonged diarrhea and then the complications of potential sepsis with C. diff.
Oh, absolutely. I mean, drug interactions, allergies, these are all things that we would see as a complication of misuse of antibiotics.
So one of the things we need to talk about is, why is this such an important thing? We need to talk about deaths, hospitalizations, and number of cases of influenza. So if you look at the CDC data for the past decade, you will see that the numbers are all over the place in terms of hospitalizations, anywhere from 140,000 to almost 1 million. You're talking about number of cases from 9 to 50 million, and you're talking about deaths from 12,000 to almost 80,000 every year. So a really wide spectrum of disease. And of course, this is going to depend on which strain is circulating at the time, but it's also going to depend on the vaccine efficacy, which can be widely variable from year to year.
The H3N2 virus strain is the one that causes the most deaths. It mutates the most, and then it's hardest for CDC to choose the best match because of its quick mutations. So it's the real bear for us.
So today we have Mr. Nickel with us, who has had multiple myeloma, he's a gentleman who is could be considered the high risk for complications for influenza. Mr. Nickel, can you tell us a little bit about your experience, your unfortunate experience with influenza last March?
Yes, I was scheduled for admission to the Cleveland Clinic for an autologous stem cell transplant on March 25th, and I suddenly started running a fever of 102.5 Fahrenheit the evening of the 24th. I had been under instructions to call the bone marrow transplant team to report any fevers, so I did call the clinic. Well, actually, I think my wife did, and they told me to come right in, so I did.
That's great. So it is very important that you heeded this recommendation and that you did call, and we're glad that you got taken care of right away. Are you aware how serious the flu can be?
I had been made generally aware that the chemotherapy that was going to be done right before the transplant would pretty much wipe out my immune system, and that any infection could be a major problem. I don't really recall if anything specific was said about the flu.
Well, I mean, catching the flu between the time that your stem cells are collected and then you get them back for your autologous transplant, this period is actually really critical, because if you get sick during that period, that could obviously make the transplant process much worse, and you could end up in the ICU or other complications related to the flu. So, Dr. Zimmerman, we know that although there are good treatments for the flu that are available, approved by the FDA and tested in very large studies, that even high-risk patients, unfortunately, do not get treated, and many of them do not get treated.
That's true. I have the privilege to be part of the CDC's U.S. Flu VE network, and we found that 15% of high-risk patients were prescribed antiviral medications within 2 days of symptom onset. That's only 15%, and obviously we should be much higher than that. There's not many contraindications to using antiviral treatment, and so we'd like to see that number more like 90%.
Any provider that has patients who are in the high-risk category, educating those patients to present as soon as possible when they have flu-like symptoms is really important. We think about this with the education that stem cell transplant patients get, who are, if you get a fever, this is an emergency. You need to contact your transplant team immediately. We need to have the same discussions during flu season with our high-risk patients, which is a much broader group of patients.
And we have to remember that the presentation of the flu in someone who's at high risk, could be immunocompromised, could be atypical. I mean, it doesn't have to be the exact sudden high fever hit by a truck that a healthy person could get and then get over quickly. These people could have milder symptoms, could have maybe a mild cough, maybe some sore throat, but obviously any of these patients hospitalized for like a pneumonia syndrome during an influenza period, we have to think of the flu, test, and treat even before we get the test result or until we get the test result.
I think for a lot of providers, when you think about clinical disease, it fits in the box that we learned about. So if you think flu, we often think fever is going to come along with that. Well, when you think about different categories of patients, it's certainly possible that some patients are going to present, they're not going to have a fever. So they don't have a fever, you're dismissing the thought of thinking about the flu, and right there you're missing an opportunity for intervention, especially in the highest risk category, potentially patients who don't have an immune system to fight off the flu.
During epidemics, you could maybe think that you could rely on a clinical diagnosis, and that's always a benefit and a drawback for specifically trying to wait for a test to make your diagnosis.
So the IDSA has an algorithm for testing and when to do it, when not to do it. There are several key questions in this algorithm. One of them is the person sick enough, whether you're using a port or other severity index for the needing hospitalization. So a second question is, will the results really impact whether you treat with antivirals or not? A third area is the issues of infection control. Is there a family member or a situation where knowing whether this is true flu or not will make a difference in how the patient or the patient's family or situation, like in a long-term care setting, is handled? And then the fourth one, and you mentioned this, was the issue of diagnostic uncertainty. If you're concerned that this may or may not be influenza, if it's out of the typical epidemic period, those would be reasons to really push and go ahead and do the tests.
I think one other thing to point out there, it's very important to understand this is an algorithm, but they don't have algorithms for every different practice setting. And you have to understand the testing and your patient population. So this is a guide, but you have to understand the context where you work when you're thinking about this type of algorithm.
I also think it's important to remember your positive and negative predictive values are really influenced by the prevalence. And if you can get data from your hospital system, from the laboratory testing there, or from your county health department about what's the prevalence, that will really inform the positive predictive value of your results.
Mr. Nickel, can you tell us a little bit about the testing and the treatment that you've received for influenza when you were hospitalized at Cleveland Clinic for the flu?
Well, once I had admitted, they performed several tests and procedures, but I really was feeling so poorly, I don't remember a whole lot about it. I do remember the flu testing, though, because they had to wake me up to put something in my nose. I was feeling so sick that if they explained things to me at the time, I really don't remember it, but so because I slept for most of the first 2 days after I was admitted. But they explained things fairly well after I began to feel better and was getting ready for discharge. I do say I was glad to be in the hospital because they took really good care of me.
Glad to hear that. So, in your experience, Dr. Zimmerman and Dr. Perkins, how do you incorporate testing for the flu in your particular practice setting?
So I work in 2 different emergency department settings, but I could also comment on urgent care settings as well. I work in an academic emergency department as well as a small community emergency department. And there is a big difference because in the academic setting we have PCR testing, which is available within an hour or two, and in our community hospital we don't. In the past few years we've used antigen testing, which has significant sensitivity issues. So the practice pattern is very different. If in the small community hospital you sometimes said, I am not going to get any testing because it's not going to change my treatment. Whereas if you're going to be able to get a PCR in a reasonable time frame, the sensitivity and specificity is excellent, and you really can make a diagnosis and make sure that you are treating patients who have influenza. However, that being said, we see sicker patients at our tertiary care center. So we try to make sure that when we're seeing patients, we know they're going to get admitted and influenza is on the differential for their illness, that we're also empirically giving them antiviral treatments.
For an outpatient family medicine situation, we do have the issues as to what tests are available. We can send people to a lab where they would have the molecular tests, but obviously that will take time in order to get the results back. If they present on the first day or so, then we would have the luxury of that time and we can do a test and treat strategy. My office does not currently have a molecular point of care test, but the molecular point of care tests are available, and there are some of them that are CLIA waived. But obviously you have the infrastructure, the costs, the whole setting to do that, but that's an option. So that's what we do. Obviously cost, CLIA certification, availability of tests are all key parts.
My experience might be a little bit skewed because, from my subspecialty in infectious disease related to transplant recipients, cancer patients, patients with leukemia and other immunocompromised patients, this is about 70% of the patients that I see. So I basically would test all of these people during, influenza epidemics for the flu if they come in with a syndrome that is either undifferentiated fever or suggestive of influenza in any way. Obviously, if they have any other specific symptoms that point to a urinary tract infection or a diarrhea symptoms or something that would lead me somewhere else, I would go there. But for the most part, during the epidemic period, I would test for the flu and start the treatment for these high-risk patients.
The testing really can make a difference, particularly in the inpatient setting. There was a study in a large UK hospital where a point-of-care test was used in one season but not in another. And in the season that it was used, there were 666 identified cases compared to the baseline of 51. That's a huge difference. They're different years, and one always has to be careful in comparing two different years. The point-of-care tests, though, vary. You can have some now that are results in half an hour, others that take 2 hours, depends on the brand. With some of them, if the test is positive, it'll even be there in 15 minutes. So as the point-of-care tests become more available and hopefully the cost drops and they are clearly waived, at least in some cases, we'll have more use of them, and that can make a difference.
Absolutely. So the three classes of anti-influenza drugs act really very differently. The older drugs, the adamantans, act by blocking the M2 receptors. The neuraminidase inhibitors, which are sort of the workforce now, as the name implies, act by preventing the egress of the virus from the cells and infecting other cells in the respiratory epithelium. And then the newest kid on the block, baloxavir, that acts by preventing replication of the virus and hence, a spread of the virus to other areas of the body. So, Dr. Perkins, can you please summarize for us the most recent Infectious Disease Society of America recommendations, treatment for influenza, particularly as it pertains to these high-risk patients?
Be happy to do so. So I think it's important to understand the concept here. The higher risk patients, they're going to get the most benefit from earlier treatment with antivirals. So much in the same way we think about sepsis, where you're giving antibiotics as soon as you can in the highest risk groups, you're doing the same thing with influenza. This even applies to patients who have had symptoms for greater than 2 days. As we know, most patients don't get their antivirals within the first 48 hours, which is unfortunate. But if they're still symptomatic after 48 hours, they will still garner some benefit. Recommendations are to choose one of the neuraminidase inhibitors. The IDSA says either oral oseltamivir, inhaled zanimivir, or intravenous peramivir. It's also important to understand, because a lot of our patients are going to ask about the single dosing of oral baloxavir. At the time the guidelines were written a year ago, the data for baloxavir was not available, so that is not addressed in the guidelines.
So, Mr. Nickel, when you were hospitalized at Cleveland Clinic, you were treated with oseltamivir right away, soon after you were hospitalized. Is that right?
Yes, that's right.
So can you tell us some of your experience in terms of lessons that you would like to tell other people with regards to the flu?
I think my only real response to that is that if you are told to report any fevers to your medical team, do it.
Great. So you presented to the hospital soon after your symptoms have developed, even though you thought it could be just a cold. You had a very high fever. You called immediately and you were hospitalized right away. You were diagnosed and treated promptly. Even before that PCR test for the flu that went into your nose
yes.
was completed. And that, I think, that is what resulted in your rapid improvement. Unfortunately, this pushed back your transplant for about 10 days, but obviously, had that not happened, this could have resulted in significant complications. Had you gone into transplant with the flu, this could have resulted in you ending in the ICU or even needing to be on a breathing machine, and even death if it was not attended to promptly as it was. So the overall clinical benefit of baloxavir, the newest drug that was approved for influenza, are similar in terms of efficacy to oseltamivir. That was the drug that it was compared to in studies that we are aware of. It has one additional benefit in terms of reducing the viral shedding, meaning the virus being shed in the respiratory secretions at a significant shorter period of time compared to oseltamivir. It's so important, though, to recognize that since baloxavir, the course of treatment is just one dose, that we better get the diagnosis right before we administer the drug. Otherwise, resistance will be an issue for this drug.
And resistance has been an issue with a number of antivirals. We think of the amantadines not being used because of high rates of resistance. We find currently about 0.5% to 1% resistance has occurred to the neuraminidase inhibitors, such as zimnaminivir and oseltamivir. However, when you look at baloxavir, the rates have been higher in some studies, and there's one study, for instance, that showed up to a 9.7 or 10% resistance that came out of data that much of it was from Japan. How that would apply to the United States is not known, but I think we have to keep an eye on it. It's led me and a number of others, I'm certainly not the first to think about this, is in the future, will we have combinations of antivirals so that we limit the issue of resistance? We think of HIV and the use of multiple drugs. We found out we can't use one. Similarly, I think we may find that we're better with a cocktail in terms of limiting resistance, but that's a research area for the future.
There's another very important point to discuss here, and it's chemoprophylaxis. The IDSA also addresses this in their guidelines in terms of which patients do you have to start thinking about more than just the patient in front of you. In my practice, I always say, where did you come from? Did you come from a long-term care facility in which you would not want to send a patient back who had active influenza, potentially endangering all of the other residents there? Do you live with a toddler? Do you have a newborn at home? This is really important questions. Is there somebody older who is maybe on chemotherapy? You would not want getting influenza. This changes things because you may have a patient in front of you who's young and healthy and does not fall into a high-risk category. Ordinarily, you would not treat, but you didn't ask the questions about what do you do, who do you live with, and where did you come from. So currently, the IDSA recommends 2 choices for chemoprophylaxis: oral oseltamivir or inhaled zanimivir as the 2 options for chemoprophylaxis if appropriate.
So currently the CDC recommends and states that we should use our clinical judgment in terms of deciding the disease severity, progression, underlying disease, age, and other important factors for decisions to treat these high-risk patients. So in your practice settings, how does that translate to your specific practice settings?
Well, I think for the high-risk patients, for which we're really talking about today, that the default is going to be to prescribe some antiviral if they have influenza-like illness and they're presenting within an appropriate time frame.
In my practice setting in the emergency department, I think it's imperative, just as in your practice settings, that we pay attention to local epidemiology. So you need to know when flu season is coming to your area.
Yeah, from my setting as an infectious disease physician specifically, taking care of mostly immunocompromised patients, transplant recipients, I pretty much would test all of these patients for the flu during flu season if they have a fever, obviously unless they have some other specific symptoms directing to another disease process, and I would go ahead and start treatment before the test result is back.
There are some other issues that one has to think about for the use of antivirals. What is the insurance coverage? Because that can be variable. The cost, if you get the discount coupons, will now drop less than $50 for oral oseltamivir, for instance, and some of the brand names are over $150. And so there's quite a difference in the cost of these, and for some patients that will make a difference. Obviously convenience, the number of doses. Zimnaminivir is an inhaled device. Some people have trouble with an inhaler, and I again think the combination treatment may be the future, though that's still in the research testing and is not to be recommended today.
So, think flu. During flu season, have a high clinical suspicion for the diagnosis when symptoms warrant it. Clinical suspicion is important, but not diagnostic. Send a test, but don't wait for the result to start treatment. Prevention and control of influenza is a dynamic field, so clinicians should consult the CDC website for the latest information about influenza epidemics, vaccines, tests, and approved antiviral medications. Thank you, Dr. Perkins, Dr. Zimmerman, and Mr. Nickel for participating in this program today. Please don't forget to take the post-test and complete the evaluation to receive the CME credit.